I'm really honored to be and very pleased to be here. Thanks from the organizing committee to invite me to this topic. As an interventional cardiologist working in Paris and in Nantes, I was asked to present you how we manage the mechanical support and the cardiogenic shock in the cath lab. And the most frequent situation we have to face in the cath lab is the acute MI, of course. We know there are many causes of cardiogenic shock and acute heart failure. The first one we have to face is the acute myocardial infarction with the mechanical complications induced by the myocardial infarction. Of course, with the COVID, we also had a lot of myocarditis. We have sometimes some Takotsubo syndrome, sustained tachyarrhythmias. Of course, we have valvular dysfunction, tumors, which are very rare, and of course, we have a unit of end-stage cardiomyopathies. But most frequent situation is the acute myocardial infarction. And as you know, this is the first cause of cardiogenic shock. And when you look at this paper of Henry in circulation, you can see that STEMI will be complicated in 3 to 8 cases, 8% by a cardiogenic shock. Look at the prognosis of cardiogenic shock in the setting of MI. This is a really bad prognosis. You can see on this circulation publication that more than 40% of the patients will die despite they have been revascularized in hospital. And this prognosis can be even worse if you look at this SCAI scale. If you go on the D or the A level, the mortality of this patient can jump until 70%, which is very high. What is the profile of this patient? These patients are older, they have more comorbidities, they have a past history of coronary disease, they often have renal or cardiac failure, and they present to the cath lab with a left ventricular ejection fraction, which is really high, really bad. There are late presenters on the table. Most of the time, it is an anterior wall infarction. There are multivessel disease patients. In 20% of the cases, the left main is involved in the disease, and also in 20% of the cases, they have a CTO artery contralateral to the vessel, to the target vessel responsible for the infarction. How do we manage this patient? And I think this is something we can share with all the cath labs in Tunisia and in general cath labs in the world who don't have very high level ICU. What do we do when we have to face these patients? First of all, check the hemodynamics, monitor the EKG in order to prevent any ventricular or ventricular tachycardia. Of course, when the patient arrives, we do biology, arterial blood gas samples, and check the level of lactates, which is for us something very important to evaluate the metabolic disorder. If we have this, if we have a bad monitoring of the hemodynamics, then we already introduce the inotropes. Noradrenaline will be preferred over dopamine, which is for us more responsible for arrhythmia. And when we do the approach to do the angio, we prefer a radial approach in order to reduce the bleeding complications, but also we prepare the groins so that we are able to implant a mechanical support very rapidly if we need so. Echocardiography is central for the management of this patient. It has been told by the previous speakers. It is very important. Before putting the patient on the table, we evaluate the left ventricular function, the right ventricular function, and of course, we check for any kind of mechanical complications before doing the angio. You know these complications, ischemic mitral rupture, septal defect, free wall rupture. Of course, this is very important to discuss and to detect this complication and discuss very early the support we are going to do for these patients. What is the strategy for these patients? The strategy for this patient is to revascularize them very early by doing primary angioplasty. When you look at the randomized study called SHOCK, doing primary angioplasty reduces, compared to the medical therapy, the mortality of this patient by 20%. There is no place and no room for thrombolysis. You only use thrombolysis or fibrinolysis, only if you cannot do a PCI strategy, and if PCI strategy is not available within 2 hours from the STEMI diagnosis. What do we revascularize? What do we do when we revascularize these patients? Do we do all the lesions or indeed a target vessel? The culprit shock answers to this question. The preferred strategy is to do only the culprit lesion compared to the multivessel PCI, because when you do so, if you do all the lesions, you increase the amount of contrast medium and you increase the risk of bleeding complication on this patient. So the guidelines now are, in cardiogenic shock, the routine revascularization of non-IRA lesion is not recommended during primary PCI. Finally, how, when, and how do we manage this patient, and how do we pose the indication of MCS? Of course, we have to recognize the clinical hemodynamics of the sign of hypoperfusion. We have to monitor and to assess the hemodynamics of these patients, either by echo and more preferably by PA catheter, evaluating the cardiac output and the PCP value. And of course, we already and very early introduce the inotropes if we think that the patient needs it. Then, if we are facing an escalation of inotropes, regarding the PCP value, the CVP value, and both, we will decide for a left-sided support, a right-sided support, or a biventricular sided support strategy, moreover, if the patient has electrical instability. For an interventional cardiology, we have all these supports who are available in 23, whether you want to unload the right ventricle with impeller and tandem heart, whether you want to unload the left ventricle with the impeller, tandem heart, or a simple mechanical support like IBP, or if you want to support and to unload both ventricles like ECMO. It depends on the situation of the etiology of the patient, of course. It depends on how much flow you want to increase in the patient. And all these supports can be introduced percutaneously unless the ECMO, which is preferably introduced by a surgical cut down. I will show you the literature, which is unfortunately very poor with the mechanical support. This is what we have easily available in the cath lab, the balloon pump, which is inflated in diastolic in order to improve the coronary perfusion and to reduce the afterload. The results is this single study, IBP2, comparing the balloon with the medical treatment, and you can see on this study there is no beneficial effect on the IBP, so routine use of IBP is not recommended in the cardiogenic shock due to ACS, and we consider the intra-balloon pump insertion only in case of mechanical complications. What about impeller? Here again, no many literature results. When you look at the retrospective analysis of the study IBP2, and we compare the series of impeller with standard treatment and impeller with balloon, here again there is no improvement with impeller comparing impeller with balloon pump or medical treatment. What about ECMO? This is a mechanical support which dramatically improve the flow, but here again no randomized studies in the infarction. But what you can see in this study published by he in 21, when you place an ECMO during the first hour, you reduce by a threefold the mortality of this patient. Moreover, if you implant it percutaneously. Sometimes we have to combine the MCS when you see if it goes off. It doesn't work, sorry. Wow. Sometimes we have to combine the MCS. When you place an ECMO, sometimes you see a lot of spontaneous contrast in the left ventricle, and you have to unload the ventricle with an additional balloon pump, for example. Finally, what works in the shock, we see that the very early and target vessel revascularization work. We see that inotropes like norepinephrine works, but for the rest, we don't have any answers, whether 2E3A works more in this setting, IBP or mechanical support. So no data, no specific guidelines for the moment. There is no magic formula. What you have to do is to discuss really early and rapidly with your local shock team, because every team is organized differently. So you have to discuss with the local team, with the surgeon, and of course with the ICU. This is what we do. We do the cath lab, we explore the patient, and then we decide what kind of support we're going to do. And what is very important after you have placed the mechanical support is to reevaluate and reassess regularly the patient, whether you are going to a device escalation if the hemodynamic is insufficient, whether you are going to a device explant, it is fortunately the patient is recovering, whether you have to withdraw the device if the clinical is futile, or if you go for an advanced heart therapy if the patient is dependent on the device. So you have, in this case, a bridge to recovery, or bridge to discussion. This is my last slide, how to optimize the cardiogenic shock. In MI, echo is very important. It is a central place for the decision, evaluating the left ventricle, the right ventricle function, and of course detecting the mechanical complication. What we know and what is sure is that the primary PCI of the target vessel, and only the target vessel, is something very sure in the management of this patient. CPI is only recommended for mechanical complications, but not very significant proof. For the rest, there is a lack of proof. There is no randomized control trial. So the choice of MCS should be based on the clinics, evaluation of the ventricles, biology, evaluation of the metabolic disorder, of course, hemo and echo invasive assessment, inotrope injection, and of course discuss with I repeat it, with the shock team discussion to customize the mechanical support for each patient. After you have placed the mechanical support, you have to regularly reassess it, either to explant it or to escalate or to go for advanced heart failure therapy or to withdraw the support if the patient is the prognostic is too bad. We'll certainly have more answers in ongoing trial and randomized trial, CPI in pre-shock situation, Impella with the ULIS and Recover IV study, ECMO in MI, randomized study which is called LCS shock, and finally combined MCS with ECMO and CPI in MI with the ANCHOR study. Thank you.